Thank you for joining us for the 4th Annual Global Summit on Kidney Innovations, Global Kidney Patient Voice, the Key to Accelerating Innovation, a collaborative partnership between the American Association of Kidney Patients and the George Washington School of Medicine and Health Sciences. My name is Kevin Fowler, and I'm a former board member for the American Association of Kidney Patients, and I continue to serve as a AAKP Ambassador for the state of Missouri. I'm also someone living with kidney disease, having received a preemptive kidney transplant in 2004. And based upon my experience of living with the consequences of polycystic kidney disease and facing the reality of kidney failure, my goal was to avoid dialysis by receiving a preemptive transplant. And my hope for all individuals suffering from kidney disease and facing kidney transplant is for them never need to go on dialysis and to receive a preemptive transplant, so that a preemptive transplant becomes more the norm rather than the exception as it is right now. And as a fellow patient advocate, or as a fellow patient, I have a deep passion for patient advocacy and patient engagement in the production and device lifecycle of novel treatments that answer the need and preferences of patients and their families. And those that are going through the journey of kidney disease firsthand, who really know what it's all about. This passion has led me into a career spanning over 30 years in both commercial and research and development roles for commercial enterprises. In addition to my role with the AAKP, I'm also the patient editor for the Clinical Journal of the American Society of Nephrology, CJSN. I'm also on the board of directors of the Kidney Health Initiative, which is a public-private partnership between the American Society of Nephrology and the US FDA. KHI has a mission to catalyze innovation and development of safe and effective patient-centered therapies for people living with kidney diseases. And for today's session on Global Kidney Patient Voice, the key to accelerating innovation, industry efforts across the globe advancing kidney patient care, I had the pleasure of conducting a series of interviews with national and global companies in the kidney space that are leading the effort to disrupt the status quo by making an investment in new treatments to address the many unmet needs of people living with kidney diseases, while also working tirelessly to integrate the patients and their unique insights along the way. In full disclosure, based upon my professional background working with life science companies, I have consulted for some of the organizations that I have interviewed. I enjoyed speaking with all these industry representatives across the globe and ask you to join me in watching excerpts of these interviews. Full interviews will be available post-Global Summit on demand on AAKP's social media platforms and YouTube channel. Thank you, and I hope you're just as inspired listening to these discussions as I was conducting them.
There is a large population at risk for kidney disease. In the United States, the two most common causes of chronic kidney disease are high blood pressure and diabetes. It's imperative that populations and people that are advocates for kidney disease and have family members that have these conditions understand and educate themselves and others in their community about these conditions. Blood pressure problems are extremely common. They can be found out quickly and correctly at most clinicians' offices. Diabetes is a complex problem. It's a metabolic problem. It involves multiple organs in the body, a lot of the vascular systems, the heart, obesity, high blood pressure, problems with lipids, and so forth. Educating each of us and others in organizations that promote health is very important. The promotion of health happens at many, many levels. We have to begin in the early ages, because this is when we know that habits and conditions that continue on in life will then cause very serious problems as we reach our 40s, 50s, and 60s. So beginning education in the home, in the community, in church organizations, and in other vehicles that we communicate with and we meet with is imperative, because even small children who are at risk and may not have any problems early on may have problems in the future. It's not well known, but even prematurity of children that are born, say, in the 24 to 30 week time range, have early conditions that might cause kidney problems because their kidneys have not yet formed. So we have to identify these high-risk groups, and high-risk groups can be in certain communities, involved with certain genetic problems, inherited, for example, if an aunt or an uncle has kidney disease. So understanding this and passing this education on, and then sharing that with as many people as we can with different types of methods. And it is very dependent on the community how messages take place. Many times it's in community forums, it's with organizations, it's with schools, it's with churches, it's with hospitals. For example, many churches do have healthcare components to them. There are Meals on Wheels, for example, and we take people to hospitals that need transportation. So as much as it sounds simple, these are the very, I think, easy ways of transmitting information about kidney problems. There's much information on websites, especially the American Association of Kidney Patients, who have a lot of resources, other organizations that might be in your local community. There's community organizations, statewide organizations, national organizations that are able to assist with the advocacy materials that are needed. In addition, many physicians are willing to contribute their time, not only physicians, but nurses, mid-level care people such as the nurse practitioners, advanced care providers, physician's assistants. There are a multitude of people that are involved in kidney care. Kidney care spans a broad spectrum of care providers. Many of them are healthcare providers, but again, there's people that are specialists in dietetics, in diabetes, in high blood pressure. There's efforts at the pharmacy levels, at community clinic levels, in order to find these populations for many, many reasons. If a person progresses to end-stage kidney disease and is on dialysis, the quality of life is very poor. Those people suffer from many, many other conditions, weak hearts, weak lungs, weak blood vessels. And so to progress to that level is both a very serious daily living experience. However, it's also a very large cost to the healthcare system. And I'm just not talking about drugs and medications and trips to doctors. I'm talking about the cost to the society itself, the cost of that person's individual trade or experience or job that they can no longer do, the cost of time to spouses or children or other friends that require transportation to sites. So the cost is very, very large, and not just economically driven by the cost of healthcare, which we know is expensive because of the Medicare costs and commercial insurance carrier costs that do end up contributing to the payment for these, but just the cost of the people that are involved, the cost of the expendables at home, bandages and walkers, and the certain diets that people need. So this is not only a cost of money and cash, but it's a cost of investment, of times, of lives, of dreams, of other things that are very, very important in a person's life. Thank you for that question. It is a very provocative question that I have heard many times over the 35 years that I've been caring for kidney patients. When I began my practice in interventional radiology, where I took care of many patients who were on dialysis and had access problems and were very struggling with the problems at hand, they did not know much about their disease process. They didn't know why they received the treatment that they had many times, and who all was involved in their care. They came in, were dropped off, and then we took care of them and went home. Over the last 10 to 15 years, there has been an expansive educational process throughout healthcare on trying to identify people at risk for kidney disease, designing specific treatment problems for those with kidney disease, understanding healthcare systems and healthcare providers who know kidney disease, and also being involved in innovative, groundbreaking trials that will advance the knowledge and innovation of kidney problems. We have learned much in this journey, and a lot of it is about the patient and the participant journey itself, that it's no longer just the participant, just the patient that has kidney disease, but we now know that there's a large system that is behind that includes the community, that these participants and the kidney patients belong to, such as their family, extended family, the care providers that give them the needed rights to visits and the facility care that they have either at home or elsewhere. They have communities within their church, with their community organizations, and nowadays even on the pickleball court. But there's also a wider community that needs to care for this population, which is in a very complex healthcare system that includes a myriad of physicians that take care of the people with kidney disease and the multiple problems that they have, as well as the doctors that may continue to change, systems that change, healthcare systems that change, whether it be a commercial or a federal CMS type of agency. And finally, there's been much innovation and discovery on new therapies for kidney disease. I've seen the progress of xenotransplantation and wearables, implantables, better dialysis access, the advent of at-home dialysis that we are now trying to propagate across many communities. So there's been an array of kidney trials, new medications, and things such as new guidelines that we need to embrace in order to manage this care. Now, each one of those systems that I mentioned do have barriers along the way. Healthcare providers may change, as I mentioned, insurance plans change, there's difficulty in access with just something as simple as transportation. And on the subject of trials, there are a lot more barriers in order to get into trials, understand about trials, or trust the trials because of the type of trials that they are. And so those are barriers that we need to meet and meet them incrementally along this pathway, and progress has been made. Now with the internet and the education that we've seen on multiple media, whether it be Netflix or Twitter or the social media accounts, there's a lot more information that people are exposed to. But is it information we trust? Do we have the checks and balances to make sure that this information is reasonable, is practical, or is truthful? We also have trials and companies that are trying to progress with the research in many ways, making it more available and organizing groups and trials that do meet the needs of people with kidney disease. An example of this is, how do we enroll patients? How do we find these populations? Where are they at? And how do we engage them with the methods that we have? And I believe with our research progress that it's going into these communities and understand each community, and each community is different. The needs are different, the social demographics are different, and just the lifestyle and everything that's addressing and facing that kidney patient is very different. So the understanding that we have more about the communities, we're able to then focus our attention on the type of advocacy, being allies that reach out and understand that population to the maximum. In addition, research organizations such as the Food and Drug Administration have set guidelines that require a broad array of participants in kidney trials, for example, that we cannot just continue to have the same trial demographics that we've had 15 to 20 years ago, but we have to now meet the general diversity in the United States and in the globe that are affected by kidney diseases. For example, a kidney disease patient in St. Louis is not going to be the same kidney disease patient that's, say, in Hong Kong or in Taiwan. Diseases vary between genetic differences, racial differences, ethnic differences, and a variety of other causes of the kidney disease. So the FDA is now requiring that there is extreme focus on patient advocacy and finding what the patient and the participant is experiencing, because they're basically the end user of this. They are the customer. They're the ones that have to be met and satisfied, and it has to work. In addition, there's been a lot of pressure now on research companies to fulfill certain requirements. I like to read something from the New England Journal of Medicine. I'm sure many of you have heard of that. It's a very prestigious journal. And the New England Journal of Medicine, in the January issue this year, and I will read this, has set aside a specific mandate for research trials. And it now requires, and I quote, that all the authors of research studies prepare a supplementary table that provides background information on the disease problem, the condition, and the representativeness of the study group to be included in that article. So they are now holding the researchers and people who are innovating and trying to do these research trials to a very high bar that requires them to now respect the diversity, to show that diversity in their trials, and at least publish the respectable nature of that within the populations. So these moves are incremental. There are many, many barriers. There's trust barriers, there's access barriers, there's cost barriers that are now being addressed and being studied. And although those barriers are there and will probably always be there in some degree, there are movements, incremental and small as they are, that are trying to move forward with the attempt. Now, one of the biggest advances is the United States Preventive Services Task Force. For those who don't know or have heard of this, but the UPSTF is an organization that looks at guidelines across all diseases. And those guidelines may be, do you need a blood count for this disease? Do you need a cancer test for this disease? 10 years ago, the kidney foundations in the United States all gathered together and asked this United States Preventive Services Task Force if there could be a guideline set up for chronic kidney disease in order to identify those people at risk for chronic kidney disease, so they would get an advanced notice, a jump on the disease in order to cause it from progressing to renal failure and dialysis. 10 years ago, this request was made, and at that time, this task force said there was not enough evidence to put that into a guideline, which means doctors do not have to test for it, healthcare systems do not have to look for it, and there you have a large population that was not getting adequate testing. About 2 years ago, 10 years later, 2020, the same organization requested once again to the United States Preventive Services Task Force to relook at this guideline request again. And amazingly, or maybe not surprisingly, the request was granted in order to assess whether now we can incorporate kidney function tests, analytical tests that will then identify at-risk populations in order to get the ball moving so that those people are aware that treatment processes can be developed, that diets can be changed, that weight loss programs can be started, that people are aware of the risks of other conditions such as high blood pressure and diabetes that will put them at risk. Now, there has not been a final decision, but this is, I guess, a good call to action to people who are supporting, who are involved with kidney care research and kidney initiatives, to now write this organization and advocate for this change so that at least we do have it and it's made part of the public policy that will then put the pressure on healthcare systems, insurance agencies, whether commercial or federal, in order to allow some of the testing to take place. So again, over the course of my career, I've seen these movements that are moving in the right direction. Are they moving as fast as we would like? No, they're not, but they are moving. And the more people we get involved as allies and as advocates, we know that this grassroots effect will then assist in the recognition and improvement in kidney care disease treatments. I work for ProKidney, and ProKidney is a biotechnology company that deals with cell therapy that's obtained from an individual's kidney who is suffering from kidney disease, and then taken and expanded in a process in a manufacturing plant that then are re-injected back into the kidney in order to potentially build that kidney back up, restore the function of the kidney, and possibly delay dialysis altogether or the time to dialysis. Our company has designed trials that are for people that are in the lower degrees and function of kidneys. For the kidney specialists that are watching this, and those who know about kidney disease or maybe your own kidney disease, there's different stages of kidney disease, stage 1 through stage 5. Stage 5 is the worst, and that's the end-stage kidney disease. Our trials are designed to treat individuals who have very minimal kidney function remaining in the stage 4 and 3B and 3 range. So these are the last two stages that are before the end-stage kidney disease. Our trials, again, are designed in such a way that we take the tissue from your own kidney, and it's your own kidney's tissue, so this is precision medicine, which then is processed into a cell mixture that promotes kidney restoration and rejuvenation, and then is re-injected back into the kidneys as an outpatient procedure. We have targeted populations that are at high risk, and these are high-risk populations who typically have diabetes and hypertension, but this is a kidney trial for diabetes, kidney disease. We have looked at regions where the highest percentage of kidney disease occurs, high-risk populations in the geographic locations in the United States, and we've been working with investigators in these sites, in these towns, in the communities, in these regions, in order to sponsor the trial and be the principal investigator for this trial. So this is a reach so that we have a very broad geographic and diverse population, because kidney disease varies in many, many ways between populations, ethnicities, and races, between ages and degrees of disease. So we have fanned across the United States with the potential for multiple trial sites in these high-risk populations. And we're going into the communities where these high-risk populations exist and trying to find principal investigators that will then engage in those populations. In addition, we have hired people that have been trained and have expertise in patient advocacy committees and programs. By that, we are looking for patient advocates in those communities, depending on where they are, what their makeup is, that actually have a voice in the community, and to reach out to them with materials, with educational topics, with outreaches of a variety of ways in order to educate those populations and inquire if they qualify or would be interested in the trial. Again, we admit and we understand trials are difficult for many people. There can be lengthy, there's a lot of visits, and so we're working in other methods for transportation, for reimbursement, for other methods in order to bring people to the clinics, or then have outreach clinics where you may be from a different area, but then are able to get to a trial that's maybe an hour or 2 hours away. In addition, we have promotional material that is very explanatory. We have team members, again, that provide outreach and other components of the trial to make it understandable, to make sure that the informed consent form is explained well in our method. We have devised a training program that is it's a three-dimensional simulation training program for all the members of our trial, that they understand completely the type of kidney disease, the diabetic kidney disease that we are trying to find, the fact that this is a treatment that involves your cells, which should not be reactive. We've not found any kind of reactive changes that are causing those problems. But again, it does require injections into the kidney, but they're very explained extremely well and in ways that people were able to ask questions and engage. We have hotlines or information lines into our system. Our website has explanations and all of the published literature that we are available, that is available to the participants so that they understand this technology, because it is very novel. The FDA has been very cautious with this type of trial, so we're under very close watch with the FDA because of the novel nature of it. But our goal with this trial, once again, is to put the word failure out of kidney disease, because failure is a failure of the treatments that we have, which now will require dialysis, some sort of hemodialysis or peritoneal dialysis or a transplant, things of that nature, or some new other innovative changes. So our goal at ProKidney is to restore kidney function to the point of slowing the disease where it does not really advance fastly, and the hope and the potential to delay dialysis or keep you off of dialysis altogether.
I'd like to thank again the vast number of industry partners that took the time to sit down and have a discussion with me. Through AAKP Global, launched in 2019, AAKP is engaged globally because we are committed to educating patients, leaders, and companies across the globe on the importance of kidney disease prevention, new innovations in treatment, and the opportunity to save more lives. We believe that united patient voice can drive innovation in the policy decisions that determine timely regulation and payment for new and safe treatments. Globally, AAKP is working with patients, medical professionals, researchers, and medical industry allies, such as those you just heard from, to cultivate a united consortium led by patients. AAKP believes that this global consortium can advance innovation and change kidney care in countries where health systems or infrastructures do not support patient-consumer choice or access to care treatments. Again, thank you to each of our industry partners for sharing with us the innovations their companies are working on or has available to improve kidney care from prevention and diagnosis to transplantation or access to care treatments.